Hello, and welcome to today's Consortium of Universities for Global Health's webinar on improving short-term global health activities, introducing the Brocher Declaration and Advocacy for Global Health Partnerships. Hundreds of thousands of people around the world, particularly from high-income countries, travel around the world and especially to low-income countries on short-term experiences. Some are run by universities, others by churches, other organizations, and tourist groups. This is a largely unregulated environment, and little is really known about the impact and costs of what actually occurs in these activities. We need to unearth what is taking place and ensure that such activities produce real benefits to the host institutions and do not cause any harm. Today, we have 4 outstanding speakers who are going to share with you how these experiences can be much more beneficial and, of course, again, cause no harm. In the order in which they will speak will be the following. Professor Judith Lasker is a Professor Emerita of Sociology of Health, Medicine, and Society at Lehigh University. She's written an outstanding book called Hoping to Help. Next, Professor Lasker will be followed by Dr. Shelley Prasad. Dr. Prasad is the Executive Director for the Center of Global Health and Social Responsibility at the University of Minnesota. And after Dr. Prasad, Professor Virginia Rothorn, who is a lawyer. She's also the Assistant Vice President for Global Health Engagement at the University of Maryland. And finally, Dr. Peter Donker. Dr. Donker is the inaugural chair of the African Forum for Research and Education in Health. He's a professor of surgery at Kwame Nkrumah University in Ghana, and he was the university vice provost. So it's my pleasure to turn it over to Professor Lasker. Professor Lasker, thank you for being here today, and over to you.
Thank you so much, Keith, and I'm delighted to be able to share this topic with all of you. I'm calling my piece of this From Critique to Research to Action, because in recent years there has been a growing critique of the short-term medical missions, as they're often called, STMMs, and there has been a lot more attention to some of the problems and how to make them better. And so I'm going to talk about a little bit about that critique. We'll hear more about some specifics of the critique of some of the problems with these programs from Dr. Donker and from Professor Rothorn in a little bit. And then lead into some of the research that I've been involved with on this topic, and finally to some activities that all of us have been involved in lately to try to lead to improvements. So first, in terms of critique, I think we could agree that the growing phenomenon that Keith described has for the most part been widely applauded and assumed that it was valuable both for the host communities, particularly the host communities, but also for the people involved. And so mostly when people have gone on short trips from high income to low income countries, they are applauded. But recently there's been a lot more attention to some of the problems with that phenomenon. And so going back 2012, one of the first books on this topic comes from Greg Seeger of Christian Health Service Corps, about some of the harms that can be caused unintentionally, both to patients and to healthcare systems by short-term missions. Not only the faith-based sector, which is a really big part of this phenomenon, but we're also seeing critiques coming from NGOs, from medical organizations, professional organizations, and academia. And I particularly want to note the pioneering work of Dr. Jessica Everett of Child Family Health International, who has led a great deal of this within CUGH and also across the US and other countries. So we have this growing critique, and we're seeing it now coming as well, not only from people who are involved in the trips or were involved and then regretted some of what they did, sort of recovering volunteers, but a group that was formed recently in Uganda called No White Saviors, which has gotten a fair amount of attention. They're very active on social media, so you can follow them on Instagram, etc. The tagline they have here, "We just know you shouldn't be the hero of the story," is, I think, really captures the essence of some of the changing views about global health interventions. That this is not just a heroic effort on the part of people from wealthy countries, but is a much more complicated phenomenon. So, given the divergent views, it seemed to me, as a sociologist, that we needed some more empirical research. What are the values? What are the harms? What are the benefits for all the various people involved? What do we know about this? So I was fortunate to be able to get some funding from Lehigh University, which has been a wonderful sponsor of this activity, for research. That was one project, and then a related project, I worked in collaboration with Bruce Compton from Catholic Health Association. And in both cases, we were looking at what it is that sponsoring organizations do, what are their practices, how do they evaluate, how do they prepare volunteers, and then also asking host community staff their views, their attitudes, their ideas, their impressions of what are some of the valuable aspects of short-term trips and what are some disadvantages. So we were able to get both those perspectives from the sending and from the hosting side. And one of the things, I suppose many of you will not be surprised, that we concluded that there were quite a few gaps between the two, that some of the common practices adopted by people who sponsor trips were different from what people in the host countries would have liked. And this publication reports on the specifics of it, but you'll see them come through in some of the recommendations that I will be talking about. So the other, if you will, product of this research is the book that Keith mentioned. And based on our findings, we recommended 9 principles for good practices, mutuality being extremely important. This is a mutual relationship, not a top-down one. You are not the hero. Continuity of programming, needs assessment driven by the hosts, not by the visitors. Evaluation, which is extraordinarily rare. Very few organizations really do good outcome evaluations. Focus on prevention, integration of different types of health services such as medical, dental, physical therapy, etc. Building local capacity, which is one of the strongest desires and preferences on the local community. Strengthening volunteer preparation, often there's very little preparation, and even staying longer in order to be able to accomplish more. So that's a very sketchy overview of some of the research findings, and having worked on this and discovering the many people who have been active and involved and trying to make a change, a group of us got together to say, okay, how do we translate this into advocacy and action? And so the first important step took place at the 2017 meeting of the CUGH in Washington, D.C., where we were able to bring together a group of 17 leaders from all the different sectors, host communities, universities, faith-based organizations, NGOs, hospitals, et cetera, and different professions, nursing, oral health, medicine, administrators. And we spent a full day discovering a shared desire for change and a real satisfaction with finding out that there were people in other parts of this enterprise who were having some of the same ideas and same thoughts and wanted to work together to see what could we do as a coalition to move things forward and towards a better situation. The coalition is led by the 4 people you see here, Shadi Prasad, who you'll hear from in a minute, and myself, and then Myron Aldrink and Bruce Compton, who I mentioned before. We meet, speak, work together very intensively and regularly, and then we also, work with a broader network of people involved in short-term missions and have regular consultations with them. Out of this came the decision to name our group Advocacy for Global Health Partnerships, with a mission to ensure that short-term global health activities are carried out ethically and make beneficial contributions to health and well-being in communities around the world, which I think is all something that we can agree on. And again, how do we get there? So we started with additional research because we were finding that lots of groups were coming up with guidelines on how to do things better. I had my 9 principles. Various organizations and individuals were writing out guidelines and principles. And we wanted to look at those and see what were the common themes and how were they being enforced. And so I'll talk about this, the research on the host country stakeholders, as well as education, networking, advocacy. So the first paper we worked on together was this one on guidelines for responsible short-term global health activities, which was a literature review, and in it we reported on the findings of 27 sets of published guidelines for improving medical missions. The report concluded that these guidelines are coming almost entirely from the global north. They were not coming from the host countries, whose stake in this is, of course, very important, if not most important, and I believe is most important, and that there was almost no opportunity for enforcement. So everybody, including myself, was writing, you know, here's what things ought to be, but you know, how does that, again, translate into action? And that is something that obviously is necessary. And you'll hear a little bit later about the legal aspects from Professor Rathhorn. We did discover that there were common themes across these 27 guidelines. And that was important to say, okay, what are most people agreeing on? And so the first 5 on this list are the common themes that appeared in most of the guidelines, but not all of them, interestingly. So the centrality of the host partner driving the program, sustainability, adherence to laws and ethical standards, preparing and supervising volunteers. There's a lot of attention to the fact that many volunteers have no skills, no preparation, and very little supervision, and that can lead to a lot of problems. And finally, evaluating outcomes. As I mentioned before, this is rarely done particularly well. We added to the guidelines themes an additional theme that emerges from a review of the research on what host partners think about short-term missions. And the finding from that review is very strong, that the concern is the need for mutuality between hosts and guests, not a top-down, you know, sending, receiving kind of attitude, and respect. There's an awful lot of concern of lack of respect of local professionals, and even undercutting the work of local professionals by providing it in a different way for free and so forth, and undermining the credibility of local professionals. Our current research project we are completing soon is designed to overcome the fact that almost all the research has been done by people like me, who are North Americans, Europeans, looking at this phenomenon. And we were, again, funded by Lehigh University to work with researchers in 3 countries that are frequent hosts of short-term missions. And they have been doing their own design and research, with working in collaboration with local health officials to look at the again, the pros and cons from their perspective, which really has to be a much bigger part of the conversation. And we'll be reporting more on that soon. And finally, as part of our education and advocacy, we wanted to bring together international health leaders, and we were able to get a grant from the Brocher Foundation in Geneva to meet. We were supposed to meet last May to talk about the next steps. Where do we go from here in terms of applying and enforcing guidelines, and mostly finding ways to activate the critique into real positive changes and improvements in short-term efforts in global health. And that leads me to introduce you to Shaili Prasad, who will talk about the Brocher Declaration and where we've come to now.
Thank you, Judy. I appreciate that lead into my talk. And I want to set the stage of how we as a group came to what we are now going to call Brocher Declaration. But first of all, thank you all for attending this. Thank you, CAGH, for arranging for this. And I'm speaking from snowy Minnesota right now. I hope you're all cozy and warm wherever you are. I would like to start off, and Judy laid a good groundwork as to the need for this, but I'd like to highlight a couple of other important parts. One, there is a conversation going on around the world right now about decolonizing global health. And I think that's an important thread for us to keep in mind, because decolonizing is about flattening structures, making sure that the power differential that has historically been present is taken away, and there is a more level conversation in all that we do. The second point that is particularly intriguing for me is, as Judy mentioned, there are many guidelines. You can pull up on the internet and see many guidelines about short-term medical missions, and a good number of them have beautiful ethical principles that frame them. But despite that, there is a tendency sometimes for these guidelines to be just prevalent in academia. How do we then convert this into more pragmatic solutions out in the field? And I think this is a critical question for us to ask, for us to answer, because until and unless whatever material we create is put into practice, what is the point about the materials being created, right? And in this particular aspect, I would like to bring in the wisdom of two of our colleagues who are not here today in this webinar, Bruce Compton from Catholic Health Association and Myron Aldring, who actually is the chairman of an NGO in Ghana, but has a strong background in business. And they were the motivators of real action-oriented steps. And I think this is important to keep in mind, because we met sometimes twice a month for about 3 years. And the opportunity of going to an international organization like the Brocher Foundation in Geneva came to us. And when that comes to one small group, nascent group, we have to really focus. What is it that we want to accomplish? And in that, our concentration was to appeal to the higher principles. And when I say higher principles, I'm talking about the philosophy or the ethics behind some of the work that's being done. I'm saying this partly because my own experience in short-term medical missions has not been a good one. I used to work amongst forest tribes in India many decades ago, and I remember short-term medical missions coming and actually upsetting the milieu there. A lot of our patients would get confused with medications being dumped or advice being changed for no good reason. So I initially had a very strong aversion to any kind of short-term medical mission. But appealing to the higher principles is the premise behind looking at the ethics behind it. And we decided to go for a document that would be a rallying document, that the declaration would hit on some of these ethical principles, and then look at converting it into practical steps next. So then the process of building this declaration becomes very important. And here, creation of the document required a lot of background research. A good amount of the research Judy already mentioned. I had the good fortune of having a wonderful research assistant, Fatima Alwan, who helped cull down a lot of the literature. And then we created a draft and we started an iterative process. The iterative process was initially run through the core group of 4 that Judy mentioned. And then we started bringing in others we knew were interested in this. Some of them are in this panel right now. We got Peter Donker, we got Virginia Rothon, we got Keith Martin, and others to also comment on this. And our goal was, before we head to Brocher, we would get a near final document. And at Brocher, we would finalize and declare the document. The key here was not to wordsmith. There is a tendency for us all, particularly in academia, to wordsmith every single sentence in a document till we are sort of paralyzed with the product. So our goal was to come up with a working document that we would all agree upon before Brocher Foundation conference in May of 2020. So I'm going to start by sort of giving you an outline as to what this Brocher Declaration is. So essentially, the structure has three components: a brief introduction piece, a nod to the core principles, and a final part of it, which is a call for action. And in the introduction, and I'm highlighting key parts of the introduction in red here, we all acknowledge that one of the primary reasons that global health needs to be doing work is to reduce disparities in health and well-being around the world. And that is key. The importance of reducing health and disparities is something very important to consider, because there is sometimes a tendency to highlight the primacy of clinical medicine. And don't get me wrong, I'm a clinician by training. But clinical medicine contributes to a very small, though important part of global health. The rest of global health is something we need to keep in mind, and the reducing disparities is something that we need to highlight. We also acknowledge that the ethical framework should be based on mutual respect, on solidarity, and the premise of social justice. The next point, like Judy mentioned before, that the community should be the critical driver. Their needs should be the critical driver of the work. And the last point captures some of the core principles that I'm sure you won't find much argument about, that the activity should be sustainable, should be asset-based, should be bidirectional, and I'll come back to that bidirectional in a minute, should adhere to appropriate legal standards, and key point of being adequately evaluated. So all of these were some of the core ideas, that some of the important concepts we put in the introductory part of it. And the next part of the Brocher Declaration has 6 core principles. The first 3 are laid out here. The part about mutual partnership with bidirectional input and learning. The bidirectionality is a term we wrestled with a lot. And the importance of this is to understand that when we are doing a global health activity, we are looking at equal partners, and we go in as humble learners in all the activities that we do. It's never a top-down, it should never be a top-down approach. It should never be a, oh, those poor people have nothing, but more along a, what is it that we can do to learn from these groups? The second principle is that empowered host country and community should define the needs and the activities. Again, that is pretty straightforward to describe. The third part is sustainable programs and capacity building. And here, one of the nods to global health activities based on long-term partnerships and based on capacity building, rather than fly-by-nights, satisfying our own curiosity or our own ego sometimes, is not the way to go. The rest of the core principles were, number 4 was compliance with applicable laws, ethical standards, and code of conduct. The legal part of it is, I think, very critical, and I know Dr. Rothon will be talking more about that. The 5th principle is about humility, cultural sensitivity, and respect for all involved. And the 6th principle is accountability for actions. So in essence, these 6 principles were, from consensus, the most important principles we thought that are needed for any short-term medical missions. Now, we've been asked this question, and I'm sure you have this question too. Shouldn't this be for beyond short-term medical missions? And my quick answer is yes, these principles are probably more universal than just short-term medical missions. But in the context of this conversation, I'm going to emphasize that these are the 6 principles that we want to emphasize in short-term medical missions. And then we finished the Brocher Declaration with a call for action as an appeal to the international community that we emphasize that this should be the same standard of care whether you're doing the work in our own neighborhoods or in another country. There should be no reason why we should come up with a, oh, but they can do with substandard care, which has been unfortunately a problem in some of the global health activities that we've seen. And the last part, recognizing that individual countries need to regulate, both sending countries and definitely receiving countries should regulate the activity in short-term global health activities. Now, as you all know, you probably heard the news, there's something called COVID hit before the Brocher conference happened. And that gave us a pause. And this is something important to keep in mind too, because we know that with the travel restrictions that the COVID pandemic created, many of the short-term medical missions were abandoned or stopped or put in hiatus. This is probably the best time for us to look at it more seriously and ask the question, going forward, should we have short-term medical missions? And if yes, how do we want to do this? So it's important for us to use this opportunity to regroup. And from our viewpoint, when we couldn't unveil the Brocher Declaration at the Brocher Conference in May of 2020, we decided to do a series of primer conversations. What we mean by that is bring a group of key actors in this field, members from academia, from NGOs, from consortia, from coalitions, and give presentations about the Brocher Declaration to get buy-in from them. And this was an important part because the Brocher Declaration, again, like I mentioned before, should not live in an academic journal and die a natural death. It should be actually put into practice in many ways. So we are now in the process of getting endorsements for this declaration. We've been doing a series of webinars, including this, as a way to disseminate the information that we have in the Brocher Declaration, and also talk about the next steps in this field. And then there is a companion articles planned, and we hope to get this out within the next few weeks and months. Now, the follow-up question, I'm sure you're asking, how can you be part of this? Number one, I would strongly encourage you to go to our website. This website has the Brocher Declaration itself. And this, you can download the declaration. If you hit the download declaration button, you can download the declaration. You can also read the declaration in detail on the website. And I'm going to also suggest that once you've read the declaration, you can click on the support form, which is a sample form that we have created. And we hope that you can put your organization's, your institution's name on it and sign off on it as a way to endorse this declaration. Again, the link to the website will be on this presentation. You can click on it and go directly to the website that houses the declaration. And once you do that, on the website, there is a site where you can email us back that endorsement, or if you have any questions or any clarifications, please email us so we can solve that issue. And now with that, I would like to hand this over to Dr. Rothon for the next part of this presentation.
Thank you so much, Dr. Lasker and Dr. Prasad, for your wonderful presentations and really for bringing me into this group and asking me to look specifically at legal issues relating to short-term experiences in global health. And I do want to thank Dr. Keith Martin and CUGH for really supporting this work and hosting webinars such as this. As Dr. Martin mentioned, I am a lawyer. That's my background. I'm at University of Maryland, Baltimore. And I am going to be referring to some research that I did with a group of folks that are involved in this effort, including Dr. Lasker, who spoke earlier. It's called Not Above the Law, a Legal and Ethical Analysis of Short-Term Experiences in Global Health, to really drill down into some of the legal and regulatory issues that come up in not all, but some of these short-term medical missions. And I think they come about in part because the principles that Dr. Prasad outlined for bidirectional and mutually beneficial partnerships aren't followed, aren't adhered to, and give license to some activities that are disturbing that I'll describe. I think from the previous presentations, you know what we're talking about, these short-term experiences that are medical missions or service learning that have participants that from high school students to graduate level students to church group members who all have different reasons for participation in these activities, from improving applications to get into universities to legitimately trying to help communities. But some of the concerning activities that we looked at in our legal paper were the setting up of ad hoc pop-up clinics that are sort of set up and then, you know, 1 or 2 days, and then the volunteers leave, and so there's limited follow-up, or placing volunteers in clinics and creating a strain on low-resource medical settings. And of course, doing little to work themselves out of a job, so to speak, by focusing on long-lasting health system improvement. So the legal concerns we identified were specifically hands-on clinical participation of volunteers lacking medical training or required licensure, importing and dispensing medical products contrary to local drug laws, malpractice and medical mistakes, and violation of patient privacy. And I can really conclude my talk now, if I wanted, by saying these are all illegal in the US and they're mostly illegal overseas. And the reason I even use the word mostly there is because we couldn't do legal research in 195 countries, but we did a broad environmental scan. And for the most part, using different names and legal frameworks, these activities are illegal overseas as well. So just to sort of give you an idea of what we're talking about, here's one high school student performing brain surgery, closing when he volunteered at a clinic in Vietnam. It's on a YouTube. The episode's called Lewis Does Brain Surgery, and the video has rousing music about what an honor it was to be asked to close this patient's surgical opening. And the website really is very clear about why this takes place overseas. The quote at the top, "Future docs abroad does not happen in the United States because of our privacy laws and insurance regulations that restrict high school and undergraduate students being in hospitals." So this group is clearly supporting clinical interaction of untrained high school students with patients. Another quite prominent case that you might be aware of is the Renee Bach case, which is she was a missionary in Uganda. She opened a treatment center, and then short-term volunteers came from the United States to help her. At least 105 children died in the care. This was an outstanding case because and one that may presage the future, because a lawsuit was brought by some of the parents of the children who died and a civil rights organization against the Renee Bach and her charity serving his children. And they reached an agreement to pay $9,500 to each mother with no admission of liability, which seems very low and insignificant, but it's a step forward in terms of bringing a reckoning for people engaged in these types of activities. So just to be clear about why licensure is important, just a slight primer, on medical licensure in the United States, it's required to practice medicine or any healthcare field, dentistry, nursing, pharmacy, in every state in the US. To practice medicine or nursing or pharmacy means to engage with or without compensation in medical diagnosis, healing, treatment, or surgery. And just to be clear, in some states, even taking a patient history is considered the practice of medicine because of the knowledge it requires to take that history appropriately. And these practice rules, these medical boards, these rules apply to health science students too, because although they don't get licensure as a physician or a formerly practicing nurse would, the boards are allowing students to practice because they're in accredited medical programs and they're supervised by physicians or nurses in that particular state. And I think it goes without saying, but just to be clear, students and others that are not in an accredited program, high school students, people without experience, are never allowed to practice medicine, as you would hope and expect. So in our research, medical licensure is every country we looked at, and beyond. We know this through international organizations have licensing boards, including North Korea, and these licensing boards require that someone coming to the country, even temporarily, gets a license to practice medicine. And the penalties are similar to the US. What is different is there is lower enforcement, but that does not mean that the rules that the board puts out are not laws that need to be followed. Every country that we researched had a temporary licensing scheme for visiting healthcare providers. Here's an example from Kenya. Any practitioner not registered in the Republic, but who, having valid qualifications from a different country and who is desirous of providing medical or dental services in the course of any humanitarian or other valid cause, shall be required to obtain a license upon payment of a fee. So what we heard during our research about what participants say about licensure, and I just want to share what we've heard and what the proper response is one very common: my US license works over there. That is not true. And even the US State Department warns against this by stating most countries will not accept a US medical license outright and will require a process to get medical licensure. Another thing, the sending organization is taking care of this for me. Believe me, you would know if this was happening because of the amount of paperwork, copies of your current license, other attestations would be asked for. So if those aren't asked for, they're not taking care of it for you. The hospital administration or clinic says it's okay. Here's the American Association of Medical Colleges saying, even if a local healthcare provider is supervising your interaction with patients or says it's acceptable for you to perform a procedure, violation of local laws may still be a punishable offense. Finally, quite common, it's too burdensome to get a license. I'm just going for 10 days. And I just think it goes without saying that convenience isn't a reason to break the law. And so that's not appropriate response. And medical students don't need licensure in the US, so don't need it in the host country. Again, as we've said, medical students in this country, well, in the US and overseas, do have clinical interaction with patients, but as part of an accredited program that is agreed to by the medical school or the local health regulatory agency. So that also is not a reason not to get licensure. Moving on to the issue of drugs, some STEG short-term groups will import drugs into countries without proper permission. In other words, just load a suitcase with drugs, take them overseas, distribute drugs without appropriate medical license to do so, distribute donated or expired drugs. And mind you, in some states in the US, there are drug donation programs, but with strict outlines about what can be donated. And again, that's quite true in other countries. You can't just distribute donated drugs or expired drugs without outside of the appropriate framework. And then some distribute misbranded or adulterated drugs. And these are FDA terms, but essentially misbranded or adulterated means repackaged, for instance, in Ziploc bags or without any accompanying instructions. So these activities are illegal in the US, and they're also illegal in the 30 countries we surveyed with regard to drug practices. The WHO has been very aware of this in 2011 and put out guidance stating that all donations really need to be based on the express need of the community. In other words, not just taking what one was able to get from a donation, and made via prearranged coordination. The distribution should be given in conformity with the government policies and administrative arrangements of the recipient country, and there should be no double standard in quality. So in other words, if the quality of an item is unacceptable in the donor country, in other words, for example, expired, it is also unacceptable as a donation. So a common response to our paper is go after organizations, use US law, Canadian law, what have you, to go after organizations that are taking part in these activities or encouraging these activities or supporting these activities. But there is a problem, and it's that US law does not apply except in very narrow and specific circumstances outside the borders of the US. It's called the presumption against extraterritoriality, and it was enunciated most recently in this Kiobel case that absent clearly expressed congressional intent to the contrary, US laws will be construed to have only domestic application, which makes sense. But it does require that we pivot from a primarily legal solution to advocacy, for instance, such as education and the Brocher Declaration are two areas that, as you've heard, have focused on addressing legal issues. There is increasing criminal and civil litigation, as you can see from the Renee Bach case in host or receiving countries. And I think, attention, risk managers, this is a problem that these cases will start developing, and it's something to really think about in terms of designing programs and making sure that they don't violate any laws. We're working with the International Association of Medical Regulatory Authorities. This is sort of a board of boards. We were supposed to attend a conference in Johannesburg in September, but that was canceled because of COVID. But we'll work with how to support medical boards in host countries and support their enforcement activities. We plan to work with US licensing boards to advocate against these practices and work with the FDA for clear guidance in this area. And although the FDA law won't apply overseas, it would help if they provided clear guidelines about what's legal and what's not. So just to conclude, a really important rule of thumb, because you can't know the law in 195 countries, but is if you're not allowed to do it here, you're not allowed to do it there. And the University of Minnesota has a Global Ambassadors for Patient Safety program that really outlines this for students, if you're working with students or if you are a student. And I think it's important to really reflect deeply on the motivations to engage in overseas medical missions. And so I want to leave with a story and a quote. This young gentleman was arrested for posing as a doctor in West Palm Beach. And he was arrested and he got some jail time. The sheriff down there said, just because you saw a season of Grey's Anatomy doesn't mean you could practice medicine. And this young man's activities were, it was reacted to with horror that he would pretend to be a doctor. And my mentor at Georgetown Law Center said this, which I think is important reaction and comment. It's quite long, but I think it's powerful. One has to ask, why would someone from the US, who by any metric would be considered a good and law-abiding citizen, travel to a foreign country and engage in activities that they know or should know are illegal in the US without asking if they are unlawful in the country in which they volunteer. What tsunami of cultural, academic, and economic forces not only supports volunteers in such behavior, but encourages it and even celebrates it. I believe it is a vestige of an outdated model of charity that distorts the value and potential of the vital field of global health. Really closing on that note, I strongly believe the Brocher Declaration is a way to move beyond this outdated model of charity and really work toward mutually beneficial, community-focused approaches to global health. And thank you for the opportunity to present. And now I will pass the mic on to Dr. Peter Donker.
Thank you. Thank you very much, Virginia. Just sort out my talk. I'm grateful to Virginia, Judy, and Shiley for the prior presentations. And they've covered most of the things I was going to speak about, which makes my life a lot easier. Hello?
We can hear you, Dr. Donker. Go ahead, please.
Do you see my talk?
Not yet.
Hello?
I see your screen.
Yeah, so, well, my talk is to, let me see, I just showing. Sorry about this.
That's okay.
Professor Donker, if you click into PowerPoint again, I think I saw your presentation right there.
Okay.
I think it's that first thing, challenges and partnerships. If you click that, it'll open up your PowerPoint.
Okay. All right. Yes.
Great. And then if you just go to the bottom with the little podium, it'll put it in full screen, or you can, yeah, great. That should work, yeah.
All right, so sorry guys. So thank you very much once again. The title of my presentation is Challenges of Creating Mutual Partnerships for Short-Term Global Health Engagements. And I am based at the Kwame Nkrumah University of Science and Technology in Kumasi, Ghana. And it's an honor for me to work with my colleagues who have spoken ahead of me. This is the brief outline of my talk, just touching on partnerships and the role of the benefits of global health engagements, challenges, and how to ensure successful partnerships, and then to conclude. So, as is well known, low middle income countries have a high disease burden and inadequate human material resources, general lack of skills and training, and limited access to grants, data, and other skills. Definitely also the COVID-19 pandemic, as was alluded to by Shiley, has shown clearly that it is not enough to be just visiting there and providing some help from time to time, but there's a need to build local capacity in this country so that when it's not possible for these visits to take place, they can take care of themselves. Several groups participate in these partnerships. ranging from academic institutions, faith-based organizations, professional associations, etc. But more importantly, the local hosts always invariably serve as the partners, and their role is so important for success of these partnerships. And so these partnerships enable the building and strengthening of local capacity, allow resources to be mobilized, and the joining of forces. And it also provides a platform for information sharing and also provides research opportunities. There's also a chance for mutual and bidirectional learning. However, because of the differences in the economies of the high-income countries and low-middle-income countries, there's a mismatch often of power with the imbalance in favor of high-income countries in terms of human resources, material resources, and financial resources. Sometimes there may be a mismatch of vision among the partners, and there may be inadequate planning and assumptions of understanding what is needed, cultural assumptions. There may be also neo-colonial and paternalistic posturing, where some of these groups from high-income countries may assume that they know what the LMICs need. Other times there may be abuse of privilege. So for instance, a privilege to provide some care in a country does not mean that you carry on services that are beyond your skills. And so, but to ensure that some of these problems are avoided, it's always important that the champions are identified and that the leaders put in place in a well-structured arrangement to support the partnership. It's also good to get a clear sense of what the partners need. It's wrong to assume that even the helpers, in quotes, from the high-income countries do not have needs. So in any partnership, it's important that both needs are clearly assessed and they are slotted into the vision, which will be well-defined and goals well set. Where training opportunities are needed, they must be provided, and so training opportunities could be both ways. One group may be needed to be schooled in the cultural practices and local norms. Another group may be actually require technical training. Important to also have a plan to ensure that beyond the initial encounter, the program doesn't just die, but it's sustained. And to ensure sustainability, of course, the rules on managing the partnership must be present. There should be respect, trust, and efforts at confidence building, regular feedback, communication, and performance evaluation with agreed on metrics should be in place. But more importantly, there should be patience and flexibility and perseverance even in the face of challenges and difficulties to ensure that the results that are expected are achieved. And of ethics and cultural sensitivity have been highlighted a lot by Virginia. How do you know that you are doing well? You have a long-term vision, which is constantly evolving as the partners develop, as the partners grow. And you may also have the whole project activity become embedded in national programs so that it's embraced and often captured in national budgets. There may be actually improvements, tangible improvements in the capacity in the LMIC countries. And there's an effort at power sharing as far as control of resources. One of the new things that people fight a lot about is data. When some research is embarked upon and some data is acquired, who looks after the data? Is it shared fairly? There has to be complete transparency and unfettered communication, and an interest in ensuring that all parties grow. So in order for these global health engagements to actually help LMIC countries to improve, they must be ethical and formal and well structured, and the goals must align with national priorities. There should be built-in plans for power sharing, the sharing of benefits, and there should be also a plan for sustainability. And as I've said already, periodic reviews of performance are essential, and the legal rights of parties and beneficiaries are to be respected. Thank you for your attention.
Thank you very much, Dr. Donker, Dr. Prasad, Professor Rothorn, and Professor Lasker. Those are excellent presentations. And for those of you who are on the line, we're going to extend this for about 10 minutes. All the speakers have agreed to do this because we have a lot of questions, and I know we want to get to them. So without further ado, I'd like to, this first question comes from Dr. Ventris, and I'm piggybacking a few more. And how do we move into the clinical and community, the churches and other organizations that are not part of academic global health programs? How is the Brocher Declaration going to move into that community? And I'll pitch this one to Professor Lasker and Dr. Prasad first.
I appreciate the question because I think the church communities, the faith-based communities are such an enormous part of global health and short-term volunteering, and are often not in connection with some of the academic work that's been done. But that was actually one of the major goals that brought us together as the advocacy group in the first place, was to bridge that gap, to bridge the various groups. And in fact, the Catholic Health Association was one of the first endorsers of the Brocher Declaration. The International Association of Christian Doctors and Dentists, Medical and Dental Association, is another early endorser. So in fact, our goal is to continue to reach across these divides. And there's also many groups involved with even evangelical missionary groups that are endorsing the Brocher Declaration. And most importantly, not endorsing is nice, but our goal is for people to use it as a tool. So that what we're seeing and hearing is that people are going to their organizations, to their churches, to their hospitals and saying, let's look at what we've been doing and how do we meet up with these principles? And that's really the goal. Shiley, you want to?
I concur with what you said, Dr. Lasker. I think one of the important things for me, Keith, has been that, about 15 years ago when I was talking about this, I felt like I was sort of the only person talking about it. And it's been fascinating to see, even when we're talking with groups outside academia and outside, our typical groups, we're seeing people recognize that this has been a problem. It's been a problem for some time. Some people are individually concerned about it. And now the voices are actually coalescing. Judy and I were involved in a conference a couple of years ago at the Task Force for Global Health. And I remember at the conference, there was a lot of faith-based groups there, and that was jointly held with the Catholic Health Association. And a lot of them came to us after our presentations and talked about, being uncomfortable with what they're doing and asking about questions about how would you evaluate? What are the principles that you should go by? So I feel that it's a right time in many ways.
Thank you, Dr. Prasad, and certainly we've seen that in your experiences in India. So this question is going to go to Dr. Donker and Professor Rothorn, two halves of the same whole, and really deals with the response from professional organizations. So Dr. Donker, what I'd like to ask you is, what are professional associations doing in Ghana and more broadly across the continent of Africa, given your previous role as the chair of AfriHealth? Are they coming together, and is there anything we can do to work with professional medical associations on the continent of Africa? And I'd like to ask you, Professor Rothorn, what has been the response from professional associations, the American Medical Association, American Nursing Association, others, to the Brocher Declaration, if you can respond to that. So Dr. Donker, first over to you.
So I'm going to keep my webcam off just for internet challenge reasons,
Yes.
to confirm that I'm from the third world, LMIC. Now with regard to professional associations, yes, surely the associations are buying into that. I think the Brocher Declaration, for instance, has been shared with a group like the AfriHealth, African Forum for Research and Education in Health, and they are interested in the principles of the Brocher Declaration. They are interested in ensuring that they work with high-income country partners to achieve maximum benefit for Africa. And apart from AfriHealth, there are other groups, the colleges of surgeons, the medical associations, and others are similarly engaged. And I think, but they are yet to be approached in a broader sense. But I think they are very much interested in the same thing of ensuring that engagements are based on mutual beneficial grounds. Thank you.
Thank you, Dr. Donker. Professor Rothorn?
Yeah, no, thanks for the question. And I would say that just as the pandemic was starting, we were starting to speak to the Federation of State Medical Boards, which is the group of all the medical boards in the U.S. And they felt that fellow feeling were very alarmed to learn about these activities and really focus on these activities, knowing the importance they place on their role here in the U.S. and patient safety and regulating the profession here, and starting to learn that medical boards also comprised of people in the same profession overseas were being overlooked, the laws not inquired about. And so it's an effort that's just beginning, but they are very concerned here and wondering what their role can be. As I said, they have very little reach beyond their state borders or beyond the United States, but on the other hand, very powerful entities in terms of education, and that's where I think that they're going to reach out to the members that are licensed by that board and tell them what is appropriate activities and the importance of licensure wherever they go, and also telegraph that to future licensees, to students who will hope to become licensed nurses, pharmacists, doctors, and I think it's creating that culture of solidarity with medical boards on both sides of the globe, all sides of the globe, to say this is wrong, and so the interest is very high.
And it shows the importance of global health law as a lawyer in global health, and we as physicians. So thankful to you, Professor Rothorn, and those in Professor Gostin and others who are advancing this work. This is a question to Dr. Prasad and Professor Lasker. You're involved in academia, you're training students. This question will go to you, and Dr. Prasad, I'll go to you first, then Professor Lasker. And it involves the teaching of ethics and empathy. And this question comes from Dr. Eichbaum. Can you share with us how academic institutions can do a better job of inculcating into the students the ethical underpinning of being a good global health practitioner? Can you share with us the work you're doing and any tips you can give to those listening today?
That's a wonderful question, and Professor Eichbaum will probably have some added information on this. It's generally a little bit of a challenge because sometimes the conversations of ethics seems a little more abstract, far away, rather than the need. Oh, well, they went and did something good and they didn't have any other options. I think one of the ways that we have approached it here is, number one, trying to frame it in the conversation of safety. Dr. Rothorn mentioned University of Minnesota developed something called the Global Ambassador for Patient Safety. If the conversation is in the framework of safety, there is no argument. People always say, yeah, we need to be safe first. Whereas if it's in the conversation of ethics, there tends to be a little tension of what is it that you're trying to aim for. I've always talked about it in terms of three driving statements. The first one is doing the right thing. The second one is doing the thing right. And the last one is the right person doing it. And I want to emphasize this. The first one being doing the right thing is where we get hung up on the ethical frameworks. And in many ways, I feel that the ethical framework question is appealing to to sort of a higher principle, seemingly abstract sometimes. Whereas the other ones, doing the thing right, is about the method of doing it. And the right person doing it is actually asking the question, who should be the one doing this? So I feel that while we're talking about ethics, it should be an active give and take and giving frameworks of conversations, and then supplant it with other frameworks, like the legal framework, like the safety framework. And only then I feel that the ethical principles will be inculcated better.
Thank you, Dr. Prasad. Dr. Lasker?
I think that a real advantage of what we've been doing is that we are part of a much larger set of cultural shifts that are going on, certainly in the university, where there's been much more attention across the board to community engagement, to reversing the top down, we're the experts and we'll tell you what to do kind of thing. I certainly saw it at Lehigh in changes in the way students were doing volunteering in the local community. No longer just, we're the rich people giving you gifts, but really, what do you need? How can we help? How can we partner together? I think this really is a shift going on, and an important one. I have talked to many organizations of students and have found them very receptive to these ideas, much more so even than I expected, because there's such a driving force to go there and do it and show how wonderful you are and get into medical school. There's so much incentive to do a shoddy job. But I think more and more university students and people across the board are seeing that it can be done better, and that everybody benefits if it's done according to good principles. And we talk about the carrot and the stick. So the carrots are often, appealing to people's common sense and understanding of what is good. And the stick, for the universities, there's always concerns about liability. And as host countries like Uganda are starting to push back and say, you can't just come here and do whatever you want. There's going to be liability issues when there are, as Charlie says, safety issues as well. So I think we're seeing both those things happening in a way that is pushing this forward and that is to the benefit of everybody involved. So I'm actually pretty optimistic.
Great. Thank you, Professor Lasker. We have two more questions and then we'll be closing because we're getting close to the end now. This one is Professor Rothorn, it's to you, and it's lead on from Professor Lasker, and then Dr. Donker will give us the last word. This comes from Jerome, Professor Rothorn, and Jerome wants to know, are clinicians treating patients overseas, are they personally liable for claims of medical malpractice once they return home?
That's a great question, and it's complicated. The answer is yes, but the local court in the setting where the mistake took place would not have jurisdiction over you to bring you, I wouldn't say you, Jerome, or whoever we're talking about, would not have the authority to bring one into court, someone into court. They wouldn't have the ability to do that. So in a sense, someone doing a medical mistake in another country would end up being judgment free because they were outside the boundaries of that country. You would never be able to travel to that country again. So that's why we talk about the important, supporting local advocates who want to do some impact litigation in that country where the victim is, where the court system has jurisdiction. But problem that people can leave the country and escape liability.
Thank you very much, Professor Rothorn. And Dr. Donker, the last question goes to you, and we understand the internet challenges you've been having. That's why you're not on the screen right now. You've held some of the highest positions at Kwame Nkrumah University and across the continent as an international leader in health and as a surgeon, a professor. Could you share with us your final words on what advice would you give to high-income institutions and low-income institutions on how collaborations can be done in a better, more impactful way to serve the needs and priorities of institutions in low-resource settings? Are there any final tips you can give to us?
Keith, so thank you very much. What I would say is that we need each other, especially for low and middle income countries, in order to improve the human development index of our people. We need to collaborate with those of our colleagues from high income countries. I also believe sincerely that high income countries also need their counterparts in low and middle income countries. And I think it's, those of us and those of you who have been involved in research know that learning is bidirectional. And it's important that we all have that humility to be willing to accept help when we need it. That is those of us in LMICs. And also those in high-income countries to acknowledge help when we receive it. I think that is what I'll say. And it's when we start on that foot of being humble, then we'll be more willing to be open about what we need from each other. I have been involved in a lot of collaborations, and oftentimes you have individuals who come from more advanced countries wanting to help the low-income country, and they are never too sure as to what they need from you. Okay, but further probing discovers that, well, they're looking to advance their career. They're looking for more publications. They need a lot more research information in a particular area. And so these are the sort of things, and there's nothing wrong with that. I think it's as long as I know that's what you need to advance your career, I'm willing to help you. And as long as I also need you to teach my surgical trainees, I'm also excited to expose them to you. But we must work in a way where there's respect for each other, respect for human rights, respect for laws of the country. But we should also have an opportunity for our own people in low-middle countries to also visit the high-income countries, to also learn firsthand what is going on there. And those are the challenges currently that we need to scale past. Thank you very much, Keith.
Well, thank you very much, Dr. Donker. And I think that was an exceptional way to end this particular webinar. You've given all of us significant words of wisdom that will certainly help to inform all of us together as we move forward with ensuring that overseas experiences are going to benefit everybody, do no harm, and as you said, is done in a context of solidarity and respect for everyone. I'd really like to thank very much, of course, the outstanding speakers that we had today, Professor Peter Donker, Professor Judith Lasker, Professor Virginia Rothorn, and Dr. Shaili Prasad for their wonderful presentations today. Please do look at the Brocher Declaration, which will be on Dr. Prasad's presentation, I believe. Take a look at Professor Lasker's outstanding book, Hoping to Help. It is an exceptional book. I highly encourage reading it. And I'd like to thank Jenna Smith, who produces these webinars at CUGH, who does an outstanding job. And thank you very much for being here today and listening to this webinar, which will be on CUGH's website, cugh.org. And don't forget our conference is coming up next March, cugh2021.org. Please take a look at it. Send in your posters and your submissions, and we look forward to virtually seeing you then. Bye for now.
Bye.